Hello and welcome to this neuro-ophthalmology talk about pupillary reactions. So to get started, I'm just going to go through the disclaimer, essentially saying this is just health information for general thinking about and educational purposes. It's not for diagnosing or treating any diseases, and if you have any sort of medical problem, make sure to see a doctor or some sort of other health professional to get some help with it. We're also not liable for the accuracy of the information presented, although I try to make these videos useful and accurate. So, moving on. We're talking about pupillary reactions, and there's two different types of reactions that we're going to think about. So one is the pupillary light reflex, and the other is the near response or near reflex. So just like any neurologic process you're learning about, you need to learn about the afferent pathway and the efferent pathway. So the afferent starts with the letter A, and that's taking light from the sensory organ going into the central system. The main pathway, when we're thinking about light and ophthalmology and optics, you're thinking about the cranial nerve 2, coming here through the retina, optic nerve, chiasm tract, back to the LGN, that's the lateral nucleus, then traveling with the radiations to the cortex, and then you have the perception of vision. I think that's the basic main pathway that we think about. But it's important, or a useful thing about the pupillary light reflex is it helps to remind us that that's not the only place that the light information goes. Light information doesn't just go from the retinal ganglion cells back into the cortex via the LGN. The light also goes to the pretectal nuclei, which are the important nuclei for the pupillary light reflex, as well as other places like the suprachiasmatic nucleus, which has its own sort of function. So let's draw out this pathway here involved in light perception. So we'll start out by just drawing an eyeball. And we know they have the retina in the back with the retinal ganglion nerves traveling in the optic nerve to the chiasm. The nasal retinal fibers will cross. The lateral ones will not cross. Then in our case, we're not going to the LGN, the lateral nucleus in the thalamus. We're going somewhere else. We're going to a nucleus called the pretectal nucleus, and this is in the midbrain. It's at the level of the superior colliculus, and it's right next to the cranial nerve 3 nucleus. All right, so this happens on each side. We're just drawing the pathways from one eye from one set of retinal ganglion nerve cells. So we go to the pretectal nucleus, and then from there, the key trivia point here is that each pretectal nucleus innervates both Edinger-Westphal nucleus, EDW. All right, so that's the afferent pathway, how the light gets into the central system and the connection it makes there. Retina, optic nerve, chiasm, goes back, doesn't go to the LGN, goes to the midbrain pretectal nucleus, which is in the sort of level of the superior colliculus, and then it has this connection between two nuclei, the pretectal and the Edinger-Westphal nuclei, which are called internuncial, or between the nucleus connection. And the trivia point is that, and it's not just trivia, it's important to think about how the reaction works, that each pretectal nucleus innervates both Edinger-Westphal nuclei. So the next part of it is the efferent pathway. So we had light coming in on the afferent with an A pathway into the central system, in our case the midbrain, part of the brainstem. Now the efferent pathway is how the nervous system sends a signal outgoing to the target structures. So this is a cranial nerve 2 through cranial nerve 3 reflex. We know that the Edinger-Westphal nucleus is like part of, or one of the subnuclei of cranial 3, or that's at least a way to think about it. All right, and the Edinger-Westphal is a parasympathetic nucleus, so our general knowledge about the parasympathetic nervous system can help us understand how this is going to work. So we have this nucleus getting input from the pretectal nucleus, sitting there in the midbrain. We know that it's going to have one projection, which is going to be a preganglionic nerve, and then we're going to go to a nucleus. Then we're going to have a postganglionic nerves going to the target structures. In our case, the ganglion is called the ciliary ganglion, so I'll just put a C there. Our general knowledge about the parasympathetic nervous system includes knowing that the preganglionic nerve is the long one that takes you most of the way there. So this is a big nerve going from the midbrain to the ciliary ganglion, which is located right near the eyeball. And then you have the synapse there in the postganglionic nerve, and the postganglionic nerve is a short nerve, just taking you from the ganglion to the target structures. And we also can remember the transmitters that are going to be involved by knowing some stuff about the parasympathetic nervous system. So first of all, we know that the preganglionic to ganglion connection will be ACH and nicotinic receptor. That's not all that unique because the sympathetic nervous system uses the same setup at the preganglion and ganglion level. But then at the postganglionic, put here a T for target structure, we know that it's going to use acetylcholine ACH, and then put a little slash here, muscarinic receptor, which is a little bit different than the sympathetic nervous system. So the target it's using the muscarinic receptors. So let's see a little bit more about the anatomy of this. So we go to the ciliary ganglion, and that's the preganglionic nerve, and that's traveling with the inferior. Go back here. So that's traveling with the inferior division of the oculomotor nerve, cranial nerve 3. Right, we talked about this as a 2-3 reflex. And after the ciliary ganglion, now it's a postganglionic nerve, and it's traveling to the target organs, or the target structures, and the specific target structures are a muscle called the sphincter pupillae muscle, and then also the ciliary muscle. So let's take a look at what this nervous system reflex is innervating. So sphincter pupillae muscle, kind of like it sounds, it's a circular muscle on the iris, part of the iris, and when it contracts, as you can imagine, it shrinks the size of the pupil. And the other muscle on the iris is a radial muscle going around here, which is more under a sympathetic control. As you can imagine, when that contracts, it dilates the pupil or makes it bigger. Then the other is the ciliary muscle. So that's located here. All right, and when that contracts, what it does is it essentially loosens up or puts slack on the zonules that are sitting there supporting the lens, and it allows the lens to conform to its more sort of natural or resting shape. So I imagine the lens being sort of pulled like this by tension from the zonules, and then if the tension is relaxed, it conforms to a sort of normal, let's just say perfect circle type shape, which gives some more accommodation or power to the system to help focus on the back of the retina for accommodation. All right, so a quick review of this pathway so far. We came from the eye, retinal ganglion nerve, through the optic nerve, went through the chiasm, crossed or not crossed. Regardless, you go to pretectal nucleus. Then you have an internuclear, internuncial connection to the Edinger-Westphal nucleus. From the Edinger-Westphal nucleus, and here we're all talking about this whole area is midbrain, superior colliculus level. Edinger-Westphal nucleus, you have your efferent, or the output. All right, that's going to be going in the preganglionic nerve to the ciliary ganglion. Then you have postganglionic nerve to the target structures, which are a muscle in the iris called the sphincter muscle. For when it contracts, it shrinks the pupil. And also you go to the ciliary muscle, which contracts and helps loosen up the zonules, allowing the lens to become more circular and help with accommodation. That's the pathway. All right, so just clinical application. The thing I wanted to bring up here is that you can use your knowledge of the pupillary light reflex to look at eyes, to look at the pupils constrict, and pick up something called an afferent pupillary defect, or a less pronounced relative afferent pupillary defect, also called Marcus-Gunn pupil, which tells you, just by looking at the pupils, that there's a problem with the optic nerve or a major problem with the retina. So let's just see how the pupil looks here. So I think there you can see the constriction pretty clearly. Let's just go watch it again. You shine the light on this pupil. You get the pupil there, you shine the light on it. It's sort of in a semi-light environment there, and it shrinks down. And then it should stay relatively the same size while the light's on it. And so an afferent pupillary defect we're talking about here is we're going to draw an iris here and a pupil here. All right, so the light's shining on this eye. So this arrow is indicating where the light is. Based on the pathways we just diagrammed, there's two reasons that we should have input coming in to the other pupil, causing a constriction that should be essentially equal to the one that the light's being shown into. One is that you have the fibers crossing at the chiasm. Remember when we drew the picture like this, we had light coming in from one eye's retinal ganglion nerves, then we had the nasal fibers crossing, the lateral fibers not crossing, going to the pretectal nucleus. Right, so from one eye, light should be going in to the other side. And then we also know that each pretectal nucleus innervates both Edinger-Westphal nuclei. Okay, on both sides. So each is innervated by both. When you shine light in one eye, you should be getting the constriction of the pupil equal in the opposite eye that no light's being shown into. Right, but we can't really see that eye very well because our light and our attention is on this eye. So what you do with the swinging flashlight test to detect the afferent pupillary defect, you take the flashlight then and you swing over to this eye. There's going to be a very brief, millisecond, momentary time where there's no light stimulus on the eye. You might get a tiny bit of dilation and then reconstriction once you get the light over there and start looking closely at it. But there really shouldn't be a whole lot of change in pupil diameter. And then you can swing it back and forth, and you should see that in a normal eye. Very little change, maybe a slight dilation and constriction just because you have that momentary lapse of light being shown on the pupil. But with an afferent pupillary defect, you have sort of a different scenario. So let's say that this, we'll draw our pupil again. So let's say that this pupil is normal. So we shine the light on here. The stimulus to this eye here, the other eye, should be full because the light's getting in through this ganglion. It's getting in through this ganglion, through this optic nerve, and going through the midbrain and getting sent over to this eye, causing the constriction. So that should be equal. Then we go over here. Let's say this is the diseased eye. And then we're shining it through a diseased retina or diseased optic nerve. The signal will not be as strong. And so instead of having the pupil size stay the same, or maybe having just a slight constriction, what you're going to see is a little bit of dilation. Usually be a little bit of slow sort of dilation of the pupil. All right, and then you come back to this eye, so you swing the flashlight back. This pupil is going to be a little bit dilated because it's going to have sort of a weak signal coming from the diseased eye. Then you swing the flashlight back, and you're going to see some constriction because now the signal is getting in there good. You swing it back, a little bit of dilation, and that's a swinging flashlight test to detect afferent pupillary defect. All right. So that's how that test works. Okay. So up to this point, we've been talking about the light reflex. So it's cranial nerve 2-3, light coming in, causing the pupillary constriction. The other reflex involved with the pupil is reaction involved with the pupil is the near reflex. And this technically isn't reflex, it's called like a synkinesis. I don't understand the exact difference. If anybody knows, it'd be great if you could put it in the comment section. But what you do is when you change your gaze from looking at something far away to looking at something close, you have a couple of processes happening. You have accommodation. We talked about the innervation of the ciliary muscle and the constriction and how you can add some power to your lens there to help focus. And you also have meiosis and convergence occur when you have the near reflex. And so the neural pathways are very similar between the light and the near reflex, and the output pathway going from along with cranial nerve 3 to the ciliary ganglion to the structures is thought to be the same, but it's not exactly the same, and there's some sort of difference in the central inputs and the processing location, because you can have something called near light dissociation. So we know that they can't be an identical pathway with identical nuclei, because you can have situations where the near reflex is present but the light reflex is absent, and that's called near light dissociation, and it brings up its own sort of differential when you have it, and that can be, we're going to talk about that in a separate talk. But I think the point is when you write, like, when people write notes about, you're going to see this a lot, right? Pupils equal, round, reactive to light, and accommodation. And generally people are writing that. They're probably hardly anyone, except for maybe like ophthalmologists or something, are checking accommodation. Most people just look in the eye with the lights and see if you're getting what appears to be a normal reaction when you shine a light into the eye. And the point here is that when you have a light reaction to light, you always have accommodation. There's no conditions that have been identified where you have a normal light reflex but don't accommodate. But there are conditions where you can accommodate but not have the light reflex. All right, so now we're moving on to anisocoria. So what this means is that you have a difference in the pupil size. So you look at someone and you say one pupil's like this, one pupil's a little bit different. And so here we're just going to talk about differential for an abnormally large pupil. In general, there's a workup for anisocoria, and part of it includes the basic knowledge that you should be aware that it's hard to tell which pupil is abnormal if one's a little bit bigger and one's a little bit smaller. You could say, is it abnormal? Is the larger one abnormally big, or is the smaller one abnormally small? But here we're going to talk about just seeing sort of a grossly large pupil, what should go through your mind, because I think a lot of times people think about this, like a herniation, blown pupil thing for what a dilated pupil could indicate, and that's kind of it. And there's a bunch of things that actually you can think about and sort of make a differential when you see a patient with a pupil. So the first one's going to have its own slide here that we talk about. It's called an 80s pupil, and that's just briefly, it's like a generally benign sort of tonic large pupil that reacts slowly, that's often idiopathic or post-viral, and usually isn't associated with a lot of serious pathology. It's going to have its own slide next to go into a little bit more. And then there's these two, which I'm grouping together as a way to think about it. So like people mention a blown pupil in terms of when you're having like a herniation, and then there's also third nerve palsy, which is a big topic, but is related to the blown pupil by anatomy. So we've been talking about how we have the Edinger-Westphal nucleus parasympathetic system going to the ciliary body and then innervating these structures to have the pupillary light reaction, and anatomically the parasympathetic fibers that we've been talking about. So that's the parasympathetic nervous system fibers are located on the outside of the nerve. So there's cranial nerve 3 traveling along to the ganglion and target structures. The parasympathetic fibers are along the outside. All right. So if you have a blown pupil from an uncal herniation, the idea is you have tissue pushing along cranial nerve 3, which is going to involve these parasympathetic fibers, which is going to interrupt the normal pathway that causes the constriction that we've been talking about, and then you're going to have a dilated pupil. You have a cranial nerve palsy, a third nerve palsy. You can have pupillary involvement or not pupillary involvement. So if you have pupillary involvement, the general thing that you think about is that you're having some compression going on. You can also call it a Hutchinson pupil, for example, a PCOM aneurysm, a tumor, some sort of other thing compressing the pupils. If you have third nerve palsy with pupillary involvement, it brings up a different differential diagnosis than if you have a third nerve palsy without pupillary diagnosis, without pupillary involvement, which brings up a differential more focused on like ischemic vascular disease, looking for diabetes, hypertension, high cholesterol, those sorts of risk factors that could cause some sort of an ischemic vascular event in a palsy of that etiology. Right, and then the other ones are physiologic. So that's someone just has abnormal pupil or unequal pupils just at baseline. That's kind of an important one, especially if you have a person who's maybe older and they can't give a good history and you don't know anything. You can't get in contact with any relative or something, because obviously if it's been there for like 30 years, it's probably not going to be all that clinically significant, but sometimes you don't know that. And so there's some tests you can do to reassure you. I mean, are you talking about something like this, or are you talking about something like this? It's a big difference. So what you can do is you can see that both pupils react normally. Is the difference in the size equal in a dimly lit room or just a normally bright room? And then is the difference relatively small or less than 2 millimeters? All right. So, and then drugs, it should make sense which sort of drugs you could give to cause a dilated or a constricted pupil. So we know that the system we've been talking about to constrict the pupils, parasympathetic system using acetylcholine, muscarinic receptor at the target site. So if you gave some anticholinergic medication, for example, like atropine, right, that would block this and cause pupillary dilation. The other thing that thinking about it the other way is if you stimulated the sympathetic system, you can get dilation. So something sympathomimetic. Also scopolamine, like someone on scopolamine patch, could cause dilation. So atropine, scopolamine. Anticholinergics will dilate. Sympathetics will also dilate. All right, so the 80 pupil is getting its own little section here, because we're not going to really talk about it in any other talks. And so what is it? It's you lose the innervation to the sphincter and the ciliary muscle, which is part of the reaction that we've been talking about. It's most commonly post-viral, which is generally thought to be sort of idiopathic. Maybe you had some sort of viral thing that you didn't really notice. A couple weeks later, you have a dilated pupil. But you can also see it after in other cases, surgeries, trauma, varicella zoster. The symptoms correspond nicely to the structures that you're losing innervation to. So you have the dilated pupil. Right? You lose the innervation to the sphincter pupillae muscle. And you can also, some people have problems with blurred vision, photophobia. So that makes sense if you're losing the ciliary muscle or innervation of the ciliary muscle, you have a hard time contracting it and you can't accommodate well, so it's hard to, so your vision can become blurry. All right, the way this presents acutely, you have a big circular pupil, a normal sized other one that either doesn't really react or is very sluggish to react to light, starts on one side and then might become bilateral weeks to months later. The way you can work this up and see if you're dealing with an 80 pupil is that, and in general when you're talking about anisocoria, which will have its own talk and how to work up, but there's a general concept to understand is that when you have deinnervation, you lose innervation to these structures, they become hypersensitive. So that's what happens here. So you lose the innervation. So the sphincter pupillae and ciliary muscles then become hypersensitive to the normal parasympathetic stimulus. So what you do is give a parasympathomimetic drug, pilocarpine, at a very small concentration, a very low concentration. You put it in both eyes, and then so the hypersensitive, denervated 80 pupil is going to have a reaction. So it'll constrict. The normal pupil won't really do much. All right, and then the two side notes to be thorough is one, if you see someone with an 80 pupil, to check the deep tenon reflexes, because although it's generally sort of viral, post-viral, idiopathic, benign condition, it can indicate a syndrome called Holmes 80 syndrome, which can be indicative of having problems more generally with the autonomic nervous system. Then after a long time, 80 pupil can shrink and become a small pupil. It's called like little old 80. So it's not always a big pupil, especially if it's more of a historical thing than a current thing. So here's a nice reference that I found that I thought was useful. You might want to read, and it goes into a lot more of the workup, but also covers some of the nice pathophysiology about the pupil and these reactions. All right. So thanks for watching, and as usual, you can visit the website for more. And if you have been enjoying these talks, consider visiting 52kids.org or the Aaron Michael Baum Foundation.org and making a donation. All right. Thank you.